Coming up on Insights on PBS Hawaii, what are our options as our lives or those of our loved ones end? Aloha and welcome to Insights on PBS Hawaii. I'm Malia Mattoch, your host for tonight's show. Before we get started, Insights has a correction regarding tonight's topic. A promotional spot that ran previous to tonight's program focused on physician-assisted suicide. Tonight's show will cover a much broader spectrum of the options we have when we face aging and illness. The continuum of care is stronger than ever in Hawaii, where palliative medicine, hospice care, and different levels of assisted living offer most residents more options for spending their final days in relative comfort. Instead of worrying about becoming a burden on family members or being betrayed by our bodies, we can now dictate some of the terms for how we approach death. What are those options? We invite you to join our conversation by calling, emailing, or tweeting your questions and comments. Now to our panel. Dr. Rae Seitz is a medical director with HMSA in the Department of Quality Management. A specialist in palliative and hospice care, Dr. Seitz oversees senior programs, HMSA's supportive care program, and the Advanced Care Video Project. She is also a founding member of Kokua Mau, Hawaii's palliative and hospice care organization. Lori Protzman is the Advanced Care Planning Coordinator at Queens Medical Center. She has been a registered nurse for more than 4 decades and has spent the last 15 years helping develop programs in hospice and palliative care. Patricia Camero is the Executive Director for Pohai Nani, a Good Samaritan retirement community in Windward, Oahu that provides assisted living services for its residents. She has been working in senior living and long-term care for 33 years. Welcome, all of you. Thank you so much for joining us tonight.
Thanks.
Thank you.
Thanks.
Dr. Seitz, may I start with you? What does it take in Hawaii to provide good end-of-life care, or shall we say even senior care through an ill period?
You know, we're quite lucky to live in Hawaii, where family structures and commitments to our loved ones historically are so strong. But just like everywhere else in the country, our families are struggling to make a go of it, you know, jobs and the economy and so on. So when someone in our families become very sick or are at the end of their life and they need care, and most of these people would prefer to be at home, a lot of the job of caring for these people fall on the shoulders of their loved ones. And that's a tough situation to be in. In that kind of a situation, I think we need to look at what kinds of healthcare delivery systems we need to build. How do we understand what is most important to the person who is facing the end of their life so that we can honor them in the best way possible?
When you say need to build, we've got a huge increase in terms of elderly in Hawaii. I think 310% increase over a 55-year period from 1980 to 2035. Are we going to have a shortage of beds in Hawaii?
I believe we already have a shortage of beds. The one place we don't have a shortage of beds is in a person's own home. So they still have their own bed. And I think as a community, we have to look at how are we going to support our elders and other people who may be at the end of life in such a way as to enable them to stay at home. Because we know that the vast majority of people, if they knew they were at the end of their life, they've told us they want to stay at home. But because we don't have a robust enough healthcare delivery system or social support systems, it's difficult for us, both as individual families but as a society, to maintain these people at home, which is where they would rather be.
Ms. Protzman, what do you see in terms of needs in this issue in our community?
Well, similarly to what Rae was sharing, the desire to die at home is key when you ask, but preparing for that and being ready for that takes planning. And what I think I've seen is the innate fear to have the conversations early on in illnesses or in the aging process, where patients and families, their families, together communicate about what's important to them, what their wishes are, so when that time nears, how can we do this as a family? Instead, what I think we see too often is that it's crisis-driven because those conversations haven't been held, and they show up in the emergency room and they're really not appropriate for acute care. They haven't made plans on what their next choices are, and they don't know how far to go with a loved one, because maybe that loved one at that point doesn't have the ability to share their wishes. So for me, from my perspective, it's how can we as a healthcare system and healthcare professionals get the word out that we need to start these conversations early, and get those wishes well known and get them well documented, so when the time does come, they can have their end of life in the place of choice.
How do you do that? It's such an emotional topic and hard, and I think for some people in Hawaii in particular, it's something that people are hesitant to have that conversation. So what are some guidelines that you give people?
You know, I like to, when it's a trick that Rae has actually given me, is to fire a warning shot, is what we call it, where I might sit down with the patient and the family and say, I'd like to talk to you about something that's not easy to talk about. And I want you to know that this doesn't have to be the only time we talk about this, but if we start now, we can help you plan for what's important later on. If I jump right in, which too often I think we do, we jump right into, well, what would you want done if your heart stopped, for instance? You know, well, the walls go up and the fear comes in, and we really don't get to the essence of what we really need to know. What are the values of this person? What are their preferences, their wishes, if they become very ill? If we plan for it, you know, and the family knows it, they can support it easier, and maybe those wishes can then be followed through.
I think that that notion of planning, of expressing what matters most to your loved one, is so fundamental to how we can do better in terms of care of people at the end of life. You know, the Institute for Medicine nationally recently published a study, a report on improving end-of-life care in the United States. And one of the things that they said was most important to do was to have these kind of conversations. Mm-hmm. But they went further and they said that the way we needed to bring people along was to create a culture change or an environmental shift in which these conversations become the norm versus the thing that's odd that only happens when you're sick. So they suggested that different stakeholders in the community actually band together, and wherever they're at, to start to advocate for these conversations to occur.
How would that happen? So ministers, for example, people in religious communities?
Right.
Yes.
In the community of Hilo, there's a very interesting experiment that's beginning. There was a new organization called Community First, which was pulled together by community leaders there, including doctors, business people, etc. And one of the things they wanted to work on as one of their first 4 initiatives was advanced care planning and having these conversations. Mm-hmm. To me, that's going to be much more powerful than trying to get all the doctors to buy into, you know, I need to have this conversation with all of my elderly or sick patients. Because to be honest with you, I've been working in this field for a long time, and there are a lot of barriers that are between a doctor and having this conversation, not the least of which, many of these doctors, they're humans, they're people too, and they feel that they're somehow letting people down if they talk about the end of life.
Mm-hmm. That's a tough topic.
Yeah.
And let's go to some questions that were emailed earlier. As more elderly are being diagnosed with some form of mental impairment or dementia, how do their families help them make good end-of-life decisions, or I suppose have these conversations where you can, when they may not have the capacity to make good choices for themselves? Ms. Camero, any thoughts on that?
You know, I know that when residents do come into Pohai Nani and there are signs that we recognize right away as far as, early signs of dementia. We often look to the family and look to them to see if there's a support system built in right away. Are they seeing what we're seeing? And we like to ease into that conversation very slowly and very carefully with them. And we work with the residents right where they're at. We try and help them to find activities that are there to meet their needs, that give them the quality of life that they're looking for. Senior wellness is a big thing at Pohai Nani. We have a lot of activities to help them to keep active. But we do see a lot of families that are in denial and they don't see it with mom and dad. They don't want to see it with mom and dad. And so it's a conversation that as trust builds between us and the family member, we bring them along. We always bring the doctor into it because we want to know, the doctor that's been working with this person all along, what are they seeing? What conversations are they having with the family and with the resident themselves?
So what if the family member does see it, is trying to have the conversation, is trying to make decisions, and because of dementia, it's very difficult? Any thoughts on that?
Yeah, I think what I like to do in these situations is explore with the family the personhood of that loved one. Tell me about them. What brought them passions and joy in the past, and explore with them who that person really was, because they're different now. And then have them step back and say, seeing mom or dad as they are today, what do you think they would say about this? What would they want their life to look like? Knowing that dementia is not reversible like some diseases are. We know this trajectory is only going in one direction. So helping them see that as they continue to decline, at what point would they step up if they could and say, enough already? And can you be comforted by that, to know that you went as far as they would be willing to do so, but not push beyond that?
So what would some of those choices be?
Well, there's many choices as they become more frail. Probably one of the biggest complications with dementia is the inability to eat and thrive, get enough calories in without the complications that go with that disease. And so families are many times put into the situation by their physician to make a determination, do we look at artificial nutrition and hydration as the next step? Because without it, they'll continue to fail, get weaker, and at some point have a natural death. If it can be presented and explored in advance of that point, when again it's not crisis driven, it's an easier conversation, I think. Mm-hmm. But if we wait as healthcare professionals, or let's say in our long-term care centers, until it's very clear that without this patient will die, then the family gets into this, oh no, what are we going to do now? So again, it goes back to that crazy word, advanced care planning. Right. Advanced means in advance of worsening disease.
And if the person has said, in that case, do not give me artificial nutrition, then it's clear.
Mm-hmm. I don't think people understand that dementia ultimately is a fatal condition. Mm-hmm. And so they think, oh, mom's fine, she looks great. And they're not planning ahead. So with dementia, it's really important that as soon as someone realizes there may be some cognitive decline, and before they lose the ability to make decisions for themselves, there has to be that conversation. And just asking people to imagine what things might be like is not enough. We have to actually show them. So one of the projects that HMSA is involved in is the use of video decision aids. And these are short films that show people and that are narrated at a fairly elementary level of literacy, but it shows people what advanced dementia looks like. Mm-hmm. What does hand feeding a person like that as opposed to tube feeding them look like? What's some of the data that we understand about that? And we've licensed a whole suite of these videos. There are now about 40 of them, that some of which we have helped to make in different languages for our communities. But these are powerful tools that enable people to understand what their choices are, what they look like, and enables them to drive their own care.
So you're wanting the person who might be ill or aging to look at these videos and know which of these would I like, would I not like this, and make those decisions. Let's get to some other questions from Dan in Honolulu. Are advanced care directories legally binding? What about the physician's order for life-sustaining treatment?
The short answer to, did you want to answer that?
No, keep going.
The short answer to that is yes, they are legally binding. The longer answer is that it's a pretty complicated social situation, very prone to people having different interpretations and so on. So let's start with advanced healthcare directives. These are legally executed documents that have certain procedures you have to follow in order for them to be legal and binding. But they express the wishes of the person executing the document. They cannot be changed by anyone except the person who has executed that document.
So if a child does not like something that's in there, the child cannot go in and say, I want this done differently.
Correct. From a strict legal perspective, that document should stand. Now, you know, people have come forward and they've said, my mother didn't really understand what she was signing, and so the document is not valid. That's an argument that gets made in court. With regard to POLS, which is a provider order for life-sustaining treatments, these are medical orders as opposed to a legal set of imperatives. So these are, this is a document that was created in the state of Hawaii. It also exists in many other states. As a way to understand the limitations that a person might put on the kind of care they would get, and to enable first responders to be able to honor those wishes. So a doctor or a nurse practitioner can sign this when the patient has had the conversation and indicated what his or her wishes are. First responders come, they see this really weird green sheet of paper.
That might be posted up on a refrigerator or somewhere visible.
Someplace prominent. They've been trained to look for that document. That document tells them, yes, I can do CPR, no, I cannot do CPR. Right.
I'd like to just focus just for a moment back on the Advanced Healthcare Directive. The key to that is the patient or the person selects who becomes their spokesperson, called a designated surrogate, healthcare power of attorney, if they can no longer speak their own wishes. That is the most important, probably, part of that, because, and the knowledge of the importance of that role being assigned. Typically, spouses will say, of course, I want my spouse, but when push comes to shove and they've been married for 65 years and it's their loved one that's dying, and even though they're the healthcare power of attorney, they have a hard time saying do nothing, just keep them comfortable, even though their loved one said that. So I'll often coach my patients and when I'm meeting with them to say, think carefully about this person, because they are you. They're to speak as if they're you, and if they can't because they love you too much, find someone else. I also recently heard for someone say, and if there's someone you don't want to speak up, put that in there too, because under stress and under times of crisis, family members come out of the woodwork and they all seem to know differently than the designated power of attorney, and it becomes really complicated at that point.
Here's another question from David in Hilo. What if our choices aren't affordable? Is there a way to guarantee that we won't end up in a situation that we don't want, like a nursing home? There's a lot of fear around aging, right? And going somewhere that you don't want to go. What are the sort of guidelines or advice that you give a family?
Oh my goodness. And you know, there is a lot of fear with nursing homes. There is a lot of fear that because of the stigma associated with nursing homes. And there are good ones and there are not so good ones.
Are there red flags? This was a question I got from a friend earlier today. If you're looking for one, are there red flags that should be an indication of something that might not be a good situation? Are there any guidelines?
You can go on to Nursing Home Compare, which is online, and it will tell you, it rates the different nursing homes in the community. You can talk to discharge planners, and I think what's most helpful for us is when folks actually come and do a tour. And I have to tell you that one of the best pieces of advice I had heard, I've had my own mom that we took care of for a long time. One of the best pieces of advice is look at the survey results, which are out there for people to look at. Look at the residents that are there in the nursing home and listen. Do you hear laughter? Do you hear the staff engaging with the residents? That's really important.
From Claire in Honolulu, can one of the panelists explain why people should be thinking about long-term care insurance? How does that work? And how important is it?
I have long-term care insurance. I think it's very important to have, because much as we might want to be cared for at home, there may come a time or circumstances where that's not a safe or reasonable thing. It is frightfully expensive.
$5,000 a month is the average, I believe?
No. You could never get anywhere for $5,000. I think it maybe starts at $9,000 to $10,000.
It's about double that,
Yeah. So and I think the price is only going to go up. So you can see where without any insurance, there's just no way. And people will end up then being Medicaid, in which case we still pay for it because it will be our taxes that then pay for that care. So I think for the most part, people should, as much as they're able to, plan for independently financing their care. Now we know that that's really not reasonable for the whole society to do that. Which is why I think we have to look beyond the nursing homes. Hospital care, very expensive, probably the most expensive. But nursing homes, and because people stay in nursing homes for very much longer than they stay in the hospital, that's a very pricey way to provide care as well. I think when we look at providing care in the home, we find that you can actually provide good care in the home by supporting the families appropriately, and it costs less. So, for example, a program that I ran at Kaiser Permanente and that I'm helping to build with HMSA, it's a palliative care program, a home-based palliative care program. A lot of communities on the mainland are looking at this particular model and duplicating it. What we do is we provide an interdisciplinary team to take care of the patient and the family, not 24 hours a day, 7 days a week in person, but by intermittent visits by doctors, nurses, social workers, chaplains, and then to be available by phone 24/7. So what palliative care teams do is they work with the patient and the family to really understand what's important to them, what are their goals of care, and then they try to organize and coordinate care around those goals to honor that patient and that family. And these teams are available 24/7, so when the patient has a new problem or a new issue come up 2 o'clock in the morning, these teams have the ability to not only answer the phone and give advice, but to deploy someone to the home at those hours.
If someone listening right now is interested in that, where do you start to find the right fit? What's a good resource?
Well, the program that Rae is discussing, supportive care, what they have done is contracted with the local hospices throughout the state to provide these services. And it's physician-driven. It has to be a referral. HMSA has provided clear criteria that allows patients to qualify. So not everybody meets this criteria. We've focused in the last year and a half primarily in the beginning on oncology patients, and more recently with heart disease and lung disease, and even a little bit expanding. I know that there's a wide vision. The beauty of this program is that by utilizing the skills and strengths of a hospice, at the point where the patient becomes appropriate for hospice care, they have built a relationship and they trust that their needs are going to be met. There's less likelihood to have to go into an emergency room for care because they've got this 24/7 contact. And then hospice, which is under the umbrella of palliative care, is a covered benefit. And so it brings these things into the home at no cost. In fact, cost savings many times.
Which is a huge. From Mike of Honolulu, what exactly is palliative care?
Go for it.
It's a specialized area of medicine recognized as a subspecialty. So people now, in order to sit for boards, have to go through a fellowship. But it's medicine that is directed at for people who have serious, maybe life-threatening illness. Doesn't have to be life-threatening, doesn't have to be a terminal condition, but these are seriously ill people who are struggling with the system, struggling with the stresses and the symptoms of a serious condition. The whole focus of palliative care is to provide comfort. And in all the ways that a person might need comfort, because comfort's not just physical. It's not just physical pain, shortness of breath, it's also spiritual. It's social, it's financial, for goodness sakes. There are many dimensions to suffering that people experience when they're faced with a serious illness. So we need a team of people who are expert in many dimensions, which is why we have an interdisciplinary team. Nurses and doctors, and now even social workers and chaplains, can get certification in palliative care. Core to palliative care is communication. So because knowing who that individual is, how unique they are, the only one on this planet, and because we believe that the care has to be tailored to the individual characteristics of that person, communication becomes very, very important. But beyond that, there are 3 other C's, I like to call them. So communication is core. The second is choice, because we think that a person is the expert in themselves. So they know what good care is. And we have to help them figure that out. But choice is a very important core element as well. Coordination of care. Because these patients are complicated, they're very sick. There are usually a number of doctors touching them, they're in and out of the system, it's complicated. Somebody's got to kind of coordinate all of that so that things don't fall through the cracks. And then lastly, of course, comfort in all the ways that they might need it.
Let me get to a few more questions. While it may seem less costly to be at home, could it end up being more if I have to go to the hospital more often? Any thoughts on that?
I can speak to a personal experience because we did take care of my mom at home. And being in long-term care myself, we chose to keep my mom at home. She had ALS, and I have to tell you, I think it was actually more expensive for us because she needed round-the-clock care that we ended up having to pay for out of pocket. It would have been less expensive for us to have her in a nursing facility. But I think it depends on your insurance as well, and it depends on what is going on with you as well.
The situation for the family.
What the medical situation is.
All right. When someone chooses to be at home and medical assistance is not accessible, as a family member, how can you consciously support those wishes knowing it could end in disaster? Have you had this issue come up and this question from family members? What would you say? What advice could you give to that?
Well, that's where the system really fails, right? Because, and that's where palliative care programs based in the outpatient setting, I think, hold tremendous potential for helping to solve this problem. We need to build that system. It doesn't yet exist. The system that exists to deal with that right now is 911, ER, and hospital. That's what exists, and that is frightfully expensive. So your previous caller is right. You know, it may be a very expensive kind of proposition. When we in healthcare look at what does it cost to provide high quality care to people at home, like this versus allowing them or just letting the situation get to a point where they're constantly coming in and out of the hospital and ER, that interfacing on a frequent basis with the acute care setting is much more expensive than managing them at home. And if you look at managing them at home, managing their expectations, honoring their choices, that is a lot more sustainable than people in a crisis going into the hospital and often ending up in the ICU on all kinds of tubes and life support. That is the most expensive place to be.
And a lot of fear, I think, for elderly people going into the hospital, a lot of anxiety, and it's not...
They know it's not a good place for them.
Yeah.
Right? Hospitals are not good places for them.
Any other thoughts on that before we move on?
No, I think that's...
All right. Tonight we're talking to experts about what options we have as we or our loved ones approach a final illness. We invite you to join our conversation by calling, emailing, or tweeting your questions and comments. Call 973-1000 on Oahu and 800-283-4847 from the neighbor islands. And we have quite a few questions. Let's go to one from Ruth via Cover It Live. How do cultural contexts shape the meaning of death beyond language access to information about health directives? So in other words, I suppose the conversation we talked about in the family, are the different cultures that we have in Hawaii more or less hesitant to have that conversation, or perhaps some of those decisions that might be at the worst of times a source of conflict within the family if an older person or an ill person doesn't want it. Have you seen examples of that?
Well, yeah, you can't generalize. Each culture is unique to itself, but so is each individual. But, you know, when a patient can hear their choices in their own language, and I'm going to go back to the use of these videos, these very short videos, I've used those as introductory tools to make their choices. And when they can see people like them, and when they realize that the decisions, when you're asked, what do you want us to do? Do you want us to do everything? The knee-jerk response is, well, yes, do everything, because the fear is that if I say no, that means you'll stop taking care of me. And that's a big part of the culture here that I've seen in Hawaii. If I can help frame it from their own perspective, in their own language, and observe them in that conversation, I'm finding that that's not really what they want. They just want it to be assured that if they're suffering, someone's going to take care of them. That's not what do not resuscitate means.
But that there will always be someone by their side.
Correct. Yeah. And you know, we've translated these videos into all these languages, and even the Pulse has been translated, so it gives the opportunity to have conversations in their own language. I think that adds comfort, and it certainly adds clarity.
This question, Ms. Camero, perhaps this is a good one for you. What if I'm in an assisted living facility and my savings run out? Have you seen something like that?
Actually, I have. And at Pohai Nani, we are very blessed. We have a foundation that works with us. It's an independent 501c3 that was established. And when we start to see somebody's funds running out, we actually work with them, apply to the foundation. The foundation uses many guidelines, much like Medicaid, and they actually work with the families, work with the resident to be able to stay in their apartment, in our independent living, right where they're at, age in place, and they help to cover the costs.
All right. Next question. What if I choose hospice, but my family wants medical intervention?
That's another confused point with hospice. People think you stop caring and treatments stop once you enroll in hospice care. And we laughingly say it's intensive caring when you're in hospice care. So you can have interventions that are appropriate to the management of those symptoms, and you can go back to the hospital if it's necessary, and it's the only way we can assure that sense of comfort. The disease, the patient, the family are treated to the last breath. And so how that looks, varies person to person, but you don't forego. And you always have a choice. People think if I sign on with hospice, that's it. No, you can always elect to stop it. If now you want to go back into treatment in a different focus, that's fine.
I think, though, that what I would like to see is a public groundswell of support for really expanding payment to hospice so that hospice can actually cover some of the things that currently they cannot afford to cover. So I'll give you an example. There are lots of oral cancer drugs, and the intent of these might not be cure. The intent might be just kind of manage these tumors as long as you can to prevent the symptoms from getting worse. So palliation using these medications. The cheapest is something like $4,000 a month. That's the very cheapest. Well, hospices get paid less than $200 a day. So you do the math. There's no way that they can sustain their business and take on that patient and have to pay for that medication. Or what we've seen is there's like one intermittent thing that needs to get done. That one intermittent thing is just too expensive. So that person cannot access hospice care. That's a shame. It's a tragedy. And it's old regulations that have not kept up with the development of the science and technology that we now have. So I would like to see the public say, don't try to restrict hospice more, which really is what the government has been trying to do in the last few years. What I would like to see is the public say, we want more hospice and we don't want it to be restricted so that I can't get the medicine that I think actually helps me.
And broaden. Here's a question along those lines from someone who had personal experience with their parent. I understand Medicare pays for a lot of things once you are in the hospice care level that they do not pay for before this level. Could you explain that?
Correct. So let's take, for example, the patient who feels better when they're on a little bit of oxygen. In order to get that oxygen prior to hospice, you have to meet certain bioparameters. They put a little probe on your finger and they exercise you. You've got to drop your oxygen levels to certain levels in order for the government to pay for 80% of oxygen in the home. For a lot of people, they don't drop their oxygen saturations to those levels, but it's undeniable that they actually feel better with a little bit of oxygen flowing in their nose. When that patient goes to hospice, there's no requirement for the oxygen saturation. The only test is, does it make you feel better? And if it makes you feel better, you can have it. Now, I'm sure people are going to say, "Oh my God, all these people are going to go wanting oxygen." Well, that's not really going to happen. And we're talking about people who you want to assess to be, at a point in time where their disease is progressive, it's incurable, and it's advanced. So that's an example of being able to get certain things in hospice care at no cost and with a lot less hassle than under regular medical care.
Very hard to navigate it, although if you aren't doing all that preparation, finding out what you... Has Obamacare made any of these issues any different, better, or worse? Or has it?
That's a good question. I don't think that it's really made care around the end of life worse. In many ways, I think that it's going to open up more availability that people might have to get care. So while it won't solve all the problems of healthcare coverage, it at least has expanded the degree to which people are covered. And during his administration, the work continues. You might recall that during his first election, there was all of the brouhaha about death panels, because ACA was to cover to reimburse the doctors for having the conversation. And suddenly it was like pulling the plug on Granny, which was a total, I think, set of lies and misinformation that went out there. Unfortunately, the industry pretty much caved to that. What we're seeing now is that those of us who do end-of-life care now have a lot more, I think, gumption, and we're standing up and saying, no, we're not going to allow this kind of craziness to dominate the conversation. Having choices and having the conversations and paying the doctors for their time and effort and skill to have that is a good thing. And we're now well on our way to getting that done.
All right, from Joanna of Honolulu, what if we don't have family in Hawaii to help make sure our wishes are carried out? Any thoughts on that?
Well, it is complicated, and it does happen. So, and you know, I don't.
Have you seen
We have that.
Yeah.
Yeah, we actually do have that. And if there's absolutely no family, we see a lot of nieces, nephews stepping up to the plate. But if there's no one, we actually communicate a lot with family on the mainland.
And of course, that might be more complex if someone is at home. So it's the sort of thing someone needs to think about. From Susan on the Big Island, I live on the island of Hawaii. There is no one who can help get power wheelchairs here. It is easier to die than to get this medical type of equipment. Is there any way I can get this help? And I suppose that's the sort of issues that you guys might see that seem quite tremendous to people when they're feeling ill or elderly. What sort of support is there for people?
So, Susan, is she in Hilo, or do you know?
It doesn't identify.
Okay, so on the Big Island. The reason I ask that is because the state has these, they're called the Area Agency on Aging, ADRCs, what they have to do with disabilities or aging, people who have more needs. And I would go look for one of these ADRCs. If she's in Hilo, they've got one up there. And the really cool thing about ADRCs is it's kind of one-stop shopping. So if you've got a question about Social Security or Medicare, or you have a need for transportation or Meals on Wheels or what have you, you can go there and they can point you in the right direction if they do not have the services right on site. So if she needs DME or some kind of equipment, she might start there. An alternative place is to work with her physician and ask her physician to make a referral to a case management company or service. So HMSA has got case managers, and if she's an HMSA member, her physician can refer to one of our case managers, and we would certainly try to help her. They would make an assessment about what her needs were, what her insurance would cover, and what the best way would be to meet her needs.
All right.
Yeah.
Good advice. Ms. Camero, Kalia from Waikiki, is it possible to put someone in a nursing home against their will? Does it take a court order? That doesn't happen, right?
No. Yeah, and you are working with the doctor the whole way.
Right.
I mean, you have to have the doctor's involvement in order for them to go to a nursing home. But if they don't want to be there, and I've seen that, they won't stay there. We've had people walk out against, not in the one I'm currently at, but I've seen where homeless have gone into the hospital and they've checked themselves out of the nursing home when they were sent to a nursing home. So if they don't want to be there, they will end up walking out of it.
Gotcha. From Joyce in Hawaii Kai, what happens if I don't want to have machines extend my life, but have no one to advocate for me? Any thoughts on that?
Go ahead.
Whoa, no, so advocating doesn't have to be a family member. It can be a spiritual connection someone might have. You can talk even to, in the legal system, there are lawyers who will agree to be appointed for your healthcare power of attorney. So, you do have options. You're not strapped. It'd be ideal if we all had someone who understood us and cared for us, but you do have options.
By looking at this. From Barbara in Manoa, my husband and I made a living will several years ago. Does that cover advanced healthcare directives and these other things that you're talking about? On that.
Living will typically has it embedded in it, but it's worth looking for it because there's many different versions of documents out there. It should clearly define their healthcare wishes, and it should also designate that the person for healthcare decision making may not necessarily be for their living will, which could be a trust for finances. Healthcare directive for health reasons and for trust purposes are totally separate, and you can choose different individuals to speak for you if you're no longer able to speak.
So just to clarify, a living will is basically synonymous with an advanced healthcare directive. There are wills, you know, for financial matters and estates and so on, but a living will is typically for medical issues. You know, Lori's absolutely right. The most important part of a living will or an advanced healthcare directive is your durable power of attorney, because you're not going to be able to necessarily plan for every contingency. And it would be crazy to try to do that. But if someone knows you and you trust they would speak with your voice, that's the person that you should talk to about becoming your power of attorney. And that really becomes your most, your strongest assurance that your wishes will probably be honored.
Respected.
For the other thing I would say is, like, for anybody who's got a living will, who's got advanced healthcare directive, who has got a pulse, periodically review what those documents say, because you just never know when your circumstances are changing, when your thinking is changing. And I would say this. I've seen all kinds of things in my career, and one of the things that I have learned is that what you think today and how you look at things today might be very different tomorrow or the next day, depending on what your circumstances are. So make sure that the people who will be in a position to either honor or not honor your wishes know what you're thinking, and make sure your documents are updated.
You know, we've had patients come into the medical center, and when we ask them if they have an advanced healthcare directive, the answer is yes. And if we don't explore beyond that point, we find out too late that the person they have designated as their power of attorney is no longer even alive. And so, you know, Rae's absolutely right. These are ongoing conversations. Our healthcare physician providers need to be checking in, you know, as the condition changes, they should be revisiting.
One of the things that you know, we're involved with at HMSA is something called our Advanced Hospital Care Program, because we know that very often people show up in the hospital and they haven't done advanced directives, or they don't know where they are, they don't know what they consist of, and so rightly or wrongly so, people who come into the hospital need to have this conversation. And so we're working with the hospitals to improve their ability to have these conversations in a very compassionate and appropriate way.
And that would be the entry point to basically making sure this conversation has been
for some of them,
established.
right.
Yes.
For some people, that may be the place they have the conversation.
This is from a lady in Kaka'ako. I am a single lady with a very low income. Where or how do I get started to get this paperwork you are discussing, living will, etc.?
There's no cost to complete an advanced healthcare directive. It can be downloaded. In fact, we have a local organization, Kakuamau, that hosts both the POLS document and a state-approved advanced healthcare directive. So what an advanced healthcare directive does require to make it a legal document is either to have it notarized, or it has to be witnessed. And the witnesses can't be healthcare professionals, shouldn't be their healthcare power of attorney who might have a vested interest in that. So neighbors or you know, people from their church or anyone, but two witnesses who can say, yes, I watched her on this day, sign it. So you need no money for that. It's what you do with it once you have it. That's the important thing. Communicate it. Make sure their provider knows that they make copies. It travels with them.
Okay, so you can go to a site like Kakuamau,
Or they can
download
go
it
to
and
their
do it.
doctor.
Or to a doctor.
Right.
All right.
So, you know, if their doctor doesn't feel comfortable doing, helping them do the documents, then they should know where else to send their patient. But Lori's right, it shouldn't cost anything to get these things done.
That's good news. From Waimanalo, I'm currently caring for my mother. She has enough money for a year or two. After that, will Medicare help to pay for assisted living?
No. Medicare typically, you need right now you need a 3-day qualifying hospital stay for Medicare to kick in, and that doesn't really even cover assisted living. That's when they go to long-term care. So Medicare doesn't typically cover assisted living at all.
So what I think Tish is saying is that, so say a person needs to go into a skilled level of care, and there are certain criteria that qualify a person to go into a skilled level of care. Currently, they need 3 days in a hospital before they're even considered for having that stay covered. And if they go into the skilled nursing facility, it's typically for things like rehab, for wound care, things like that, or maybe for certain IV medications or what have you. So it's for a limited purpose. Now, sometimes when people get really sick, they go to the skilled nursing facility, but then they can't really go back home. Time, they don't really benefit from the physical therapy or whatever, and they can't return to an independent level of living. Now we're looking at longer term care, and we're talking now about ICF level of care or intermediate level of care. When a person is at a lower than skilled level of care and they don't have funds, then they apply to the state for Medicaid coverage, and Medicaid would then cover, under certain circumstances, that residential care.
There are also a few care homes, so if they don't need long-term care in a nursing home per se, and if they could go to a care home, and we have many care homes in Hawaii, there are a few care homes that will accept Medicaid.
And that would be a lower cost option, obviously.
It would
and
be
more
a lower
coverage.
cost.
Right.
All right, so that might be a place to look. We're nearing the end of the program. Let me end by asking each of you, from your perspective, this question as well as broader, any last words of advice. What can families do to offset the cost of dying? That's from Mike in Hawaii Kai. If you're looking long range, you're wanting to be organized, what are some steps that you can take to reduce the cost for yourself and your family and also make the process a more peaceful process? Any thoughts on that in terms of advice?
Again, I'm going to go back to having the conversations early and determining what's important as they near the end of life. Tapping into the resource of hospice early. We fail miserably in using that resource that we have available. We're one of the lowest users in the
Is that right?
in the U.S. I think we're about 45th, 46th of 50.
It depends on if you
on
measure
which-
Oahu or if you measure the whole state.
Yeah.
Any thoughts on why?
Well, I think that's another whole big conversation, but a lot of it goes again to fear of talking about end of life, exploring their wishes in advance, and feeling that if they go with hospice, it's because they gave up, rather than seeing it as an added level of support to make their wishes happen in a place that's meaningful with people there to a network to reach out to.
People find the word a bit scary when they shouldn't.
They totally do.
All right. Ms. Camero, any thoughts?
I totally agree with Lori. I think they need to talk about it early on. I wished that everyone would start planning early. I mean, you don't need to be a senior citizen. Think ahead. Think about what you want, and then start having those conversations with your family. Let them know what your wishes are. And I totally agree with Lori on the hospice, because I have experience many times over where by the time they actually move into the hospice system, they're only there for a couple of weeks. And they would benefit so much by being in hospice and having the benefits, not only for themselves, but for their family members.
So it should have been a much longer period in hospice, and it would have been more peaceful for everyone.
Yes,
and easier.
absolutely.
All right.
One of the most common things that we've heard for patients who did eventually go to hospice was, why did I wait so long?
Yeah.
What was I afraid of? These people are wonderful. That's the most common comment that we hear.
Yes.
But, you know, I think that there are communities on the mainland where they've focused a great deal of effort on advanced care planning and really understanding what's important to individual people. And those communities have shown that almost none of their people are dying in the ICU.
Yeah.
Very few are dying in the hospital. Many more of them are accessing hospice care, because here's the thing. When you can get over that barrier, that fear of having the conversation, people actually make pretty good decisions about their care when they understand the circumstances that they're in. I have a tremendous amount of trust and confidence in our citizens that they can understand what their particular illness or condition is, and that they make smart choices when they're armed appropriately.
Just once we've removed sort of the fear and some of the silence around it.
Yeah.
Absolutely.
Right.
All right. Thank you so much for all the wisdom you guys have shared tonight. Really appreciate it.
Thank you.
In 2 weeks on Insight, statistics show that the number of domestic violence cases are declining in Hawaii, but the state still served more than 7,300 victims in 2012. What assistance is in place to help abuse victims out of dangerous living situations? What more needs to be done? On the next Insights, how can we combat domestic violence in our community? I'm Malia Mattoch. A hui hou.